Welcome to the presentation for Module 10. This is Part 2. Part 2 will discuss peripheral venous disease. It's important to understand the function of the veins in the body. Remember, veins are the vessels that carry the blood back to the heart. The deoxygenated blood is what they're carrying back up to the heart. They have to have competent valves. The valves is what helps propel the blood back up towards the heart. This requires the assistance of strong muscle beds around the veins in order to help get this blood pumping. If one of the more veins is not operating properly, they can become distended, and then clinical manifestations occur, and we'll discuss those in the following slides. This is just a good slide as a visual as the comparison and contrast of arterial disease and venous disease. Remember, your arteries require the pumping mechanism of the heart in order to pump the blood out to the deoxygenated blood, out to the periphery, out to the tissues in order to provide oxygenation to the tissues. There can become plaque buildup within the arteries that can impede blood flow. In the venous system, we're talking about not necessarily plaque buildup. We are talking about typically some valve problems that occur if the valves are incompetent or not working appropriately. The blood flow will be impeded back up to the heart, so then the blood will pool in the periphery and cause an engorgement and stretching of these veins. And this will cause the venous disorders that we will discuss in this presentation. This is a list of the venous disorders that we will discuss for this presentation. Venous thrombosis, which is a clot within the veins. Varicose veins, which is engorged, swollen veins due to incompetent valves. Chronic venous insufficiency is basically the cause of varicose veins. It means that the valves within the veins are incompetent and they cause venous insufficiency. And venous leg ulcers are a result of prolonged venous insufficiency. Venous thromboembolism is essentially discussing a blood clot that can occur within the venous system. It's also known as a thrombus, a venous thrombus. It is specifically called a deep vein thrombosis, or a DVT, when it occurs in one of the deep veins. These things can occur in the superficial or the deep veins. We know that as healthcare workers, this can occur as a result of prolonged hospitalization, endothelial injury, and hypercoagulability, which is known as Virchow's triad, and we will look at Virchow's triad in the next couple of slides. But we know that this is something that we can prevent if we implement interventions that are known to prevent blood clot from occurring in the venous system. The purpose of making sure that we prevent this from happening is because a dislodged venous clot can be dislodged and travel to the lungs, which can cause a very serious complication known as pulmonary embolism. So there's lots of different reasons why we need to make sure that we prevent this from occurring. This slide is just kind of clarifying some of the vocabulary related to venous disorders. Thrombophlebitis is basically an inflammation of the venous system that can lead to a thrombus. It can occur in superficial veins. It does, however, most frequently occur in the deep veins. And that would be called a deep vein thrombophlebitis, which is a clot caused by inflammation in the venous system. And again, we're mentioning that risk of having a PE, which is a dislodged blood clot that travels to the pulmonary artery, which can cause acute respiratory distress in your patient. At the bottom of the slide is the DVT, the deep vein thrombosis. That's just a term referring to when this deep vein thrombophlebitis occurs in one of the deep veins. The important thing to remember, a clot can occur in your venous system. It is not associated with atherosclerosis and arteriosclerosis like your arterial clots. This occurs due to incompetent valves and some inflammation that can occur in the lower extremity due to a surgical procedure, or Virchow's triad, which we'll talk about which is 3 different things that a hospitalized patient might occur. And so this inflammation leads to a pooling of the blood, and we know what happens with inflammation. Inflammation occurs, and then our body sends in platelets and inflammatory mechanisms that can lead to a clot. So it's a little bit different cause here. It's not the atherosclerosis. It's just important to understand that when we talk about the venous system clots. It's a little bit different situation. And that's why a hospitalized patient is at high risk for developing a DVT, because of the different things that might occur while they're hospitalized that put them in a perfect storm situation for developing a clot in their lower extremity, which can impede the flow of blood back up to the heart, and it can also, this clot right here can travel up to the pulmonary artery, causing a very serious condition in your patient. Here's that slide that's discussing Virchow's triad. The thrombus formation has been associated with stasis of blood flow, endothelial injury, and or hypercoagulability. And those are discussed in the next slide in more in depth. So these are some examples of the things that can cause the hypercoagulable state here, which is different kinds of acute situations. Acute phase post-op, that's the most common reason that we see in a hospitalized patients that put them in a hypercoagulable state. Usually that's due to some dehydration occurring. Over here, the endothelial injury, any kind of a surgery is an endothelial injury. Any kind of a catheter, any kind of a, this could also, indwelling catheter could also be referring to possibly IV placement. And then your venous stasis, we know that that occurs in an immobility state. When your patient is not up and moving, that causes stasis of blood flow. So think about patients that you've had in the hospital. How many of them have all 3 of these different situations in Virchow's triad? So basically what Virchow's triad is saying, when these 3 things exist, hypercoagulable state, endothelial injury, and venous stasis all occur at the same time, this is what puts a patient at risk for a thrombophlebitis, which can lead to a deep vein thrombosis, leading to possible life-threatening situations. So these are some preventive measures that we can do in a community patient and an inpatient. One thing that is to take note of is oral contraceptives in women puts them in a more hypercoagulable state. This is very, very specific in women who are over 40 and smoke. Most providers will not prescribe an oral contraceptive for women who are over 40 who smoke, because it puts them at double risk for developing blood clots. It puts them at a very hypercoagulable state. So that's just to make sure that we know that would put a patient at risk for sure. Definitely dehydration. Everybody needs to drink adequate fluids to keep our blood hydrated and thin. Inpatient, you guys are doing these things probably in your clinical setting already, these inpatient interventions to prevent any type of a venous thrombus. Of course, education, ambulating, adequate hydration, all of those TEDHOs, those SCDs, are all interventions implemented as prevention. Because remember, most of your hospitalized patients have all those risk factors of Virchow's triad, so we have to do what we need to do in order to prevent them from getting any kind of a clot in their venous system. Signs and symptoms of venous thrombosis are sudden onset of calf or groin tenderness. One of the interesting things to note is it's usually unilateral, because usually a clot will only happen in one leg. It can happen in both, but usually it's one-sided. So if somebody has a sudden onset of unilateral swelling, pain in one of their calves, you need to suspect that they have developed a clot. It's localized edema in one extremity is very suggestive of a DVT. Measuring the calf can help us to determine how much bigger. So if we suspect that there's swelling in one calf, it can be very helpful to measure each calf and compare them to determine and say, yes, the right calf is definitely swollen. It's 2 centimeters greater in circumference than the left. And then you monitor that to see if it gets any worse. So remember, in healthcare and nursing, we always like numbers, specific numbers. So it's very important to, like, measuring would be a good supportive data to support that, yes, there is indeed swelling in this unilateral leg, and we might need to do more diagnostic testing to determine if indeed a clot is there. A D-dimer test is a diagnostic blood test that can be drawn in the incidents that we suspect a venous thrombosis. So this is in those patients who have all the 3 risk factors of Virchow's triad, and then we notice an acute edema and pain in one of their calves, say their right calf. We've measured the calf, and the calf is indeed a couple centimeters larger in circumference than the left. So we might get a blood draw. It's a D-dimer blood draw. D-dimer is elevated in a patient who has the products of clotting. So it's a global marker of coagulation activation and measures fibrin degradation products produced from fibrinolysis. So basically, if the D-dimer is elevated, that is indicative that there is a clotting cascade occurring within the body. It is useful as a supportive diagnostic tool to say, yes, indeed, there is a clotting, there is some clots occurring in this patient's body. A negative D-dimer would exclude a DVT. So if it's negative, then that means there is no clotting occurring in the body. So that would tell us that there isn't not a clot that we suspect. If it's positive, it supports that, yes, there is a clot. The actual gold standard for diagnosing for a thrombosis, a venous thrombosis, would be an ultrasound. We would need to do an ultrasound on that leg, and that would confirm a clot. If we diagnose a patient with a venous thrombosis, we need to prevent any complications from occurring. That complication of a priority would be that that clot dislodges and travels to the pulmonary artery, causing an acute respiratory distress. We also want to prevent any further thrombus from occurring, because we know that once we have a clot in the body can kind of recognize that as an injury and maybe try to send more platelets in to create more clots, but we have to prevent that from happening. And patients who are diagnosed with a clot may require hospitalization if they aren't already in the hospital. A lot of times they're already in the hospital, but they will have to be brought in. Heparin is usually the anticoagulant of choice, and this is what the heparin is targeted at. It's targeted at preventing any further thrombus formation in the body. That heparin is usually initiated as a heparin infusion. You've done some dosage calculations related to heparin's infusion, and we'll continue to practice that because, like I said, that's the treatment of choice for a diagnosed venous thrombosis. Besides initiating a heparin infusion, elevation of the legs is usually required. And then you know that you put those sequential devices on, those SCDs, those compression stockings. Those are targeted at improving the blood flow up to the heart. It's really important, though, that we do not massage that area because that could promote dislodging of the clot. Monitor all patients for signs and symptoms of a pulmonary embolism. As I mentioned, heparin is the first line of treatment typically for a diagnosed DVT. And that's an infusion, and that's to prevent any further clots from occurring. One thing as far as activity of this patient is usually what we do is we restrict their activity. We put them on bed rest and elevate their extremity until we get them therapeutic on the heparin, which means we get them into an anticoagulated state. We monitor that anticoagulated state by a blood test called an APTT. We do it initially after we start the heparin infusion. We do it every 6 hours until the patient has reached a therapeutic level, which can be found on the order for the sliding scale for the heparin. So essentially we kind of adjust the heparin infusion until we get the patients to a anticoagulated state. Once they are in an anticoagulated state, then we can ambulate them. Then they can get out of bed. Warfarin is also an anticoagulant. It's an oral anticoagulant. And essentially what we do is in the hospital, we get them treated with heparin because heparin infusions work very quickly to prevent further clot formation. And then we bridge them over to an oral anticoagulant, and it's usually warfarin, so that they can go home on an anticoagulant. Because usually the clot will not go away immediately, so they need to go home on an anticoagulant as well. So warfarin is that oral anticoagulant. We bridge them over. We usually get them therapeutic on their heparin infusion. And then we start warfarin, PO. And then we monitor a different blood test, which is known as a PTINR. The PTINR is the labs that tell us if warfarin is therapeutic. In other words, if we get them to an anticoagulated state with their oral anticoagulant. Once we get them therapeutic on warfarin, we will stop the heparin drip, and then they can get ready to go home. Normal INR levels are 1.3 to 2.0, and that is the lab that we pay the most attention to. It's international ratio for a therapeutic warfarin. Therapeutic range is thought to be between 2 to 3. Some patients, they target them to be 3 to 4, but essentially they want a therapeutic patient is 1 to 2 times higher than the normal level. So normal level is 1.3 to 2. So therapeutic is considered from 2 to 3 usually in most patients. We do monitor frequently to make sure that the patient isn't over anticoagulated, because that can mean put them at risk for excessive bleeding, which could be a life-threatening situation. And we do make sure that they are getting enough of the medication that they don't become, they're not anticoagulated enough, and so they end up having complications due to clotting. So we have to keep them in a nice range, in the therapeutic range. So that's why we monitor their blood levels very frequently when they're anticoagulated. The other piece of this is there are antidotes for both of these medications in the event that the patient would get too much and have too thin blood. Heparin, there is an antidote, and it's called protamine. So in the event that their APTT levels get too high, which is typically considered greater than 36, a patient may need to have some protamine infused, and it's usually given IV to counteract the effectiveness of the heparin so that they don't end up bleeding too much. Antidote for warfarin is vitamin K. So that's an easy one to give. So in the event that their INR gets maybe around 5 to 6, we might have to give them a dose of vitamin K to counteract the effectiveness of the warfarin, so because their blood is too thin. Warfarin, so vitamin K can be obtained within the diet, so education on a patient who's taking warfarin would include telling them not to eat excessive amounts of foods that have vitamin K in it. That's because if they do, then we will never get them therapeutic, because the vitamin K in their diet will continuously counteract the effectiveness of the Coumadin. So patient teaching is to avoid foods that have excessive amounts of vitamin K, and usually that's your leafy green vegetables. So we don't really have a problem with a lot of patients overdoing their vitamin K intake. Venous insufficiency is just a term that typically just describes when someone has damaged valves in their veins, usually of the lower extremities, that prevents blood flow back up to the heart. And so what results is stretching of the veins, which is called venous hypertension. It increases the pressure within the veins because the blood is stasis there and it's not moving forward up to the heart as it should. And this results in edema in the lower extremities due to the pooling of blood due to the lack of the effectiveness of the valves to propel the blood back up to the heart. This can be chronic, and this usually occurs in people who possibly have jobs where they stand for long periods of time. And what that does is it damages the valves because the valves are constantly working really hard when somebody is standing to get the blood back up to the heart. Typically occurs in people who stand in one position for long periods of time, like teachers, factory workers who stand and run a machine all day long for 8 hours and stand in one spot. They're excessively at risk for this. Nurses are at risk as well because they usually stand for long periods of time, especially if they're maybe in the OR or doing a job or standing by a diagnostic tool or something like that and standing for long periods of time. Obesity is also something that puts a patient at risk for venous insufficiency. The pressure of the weight on the veins can damage them. And anyone who has a history of a thrombophlebitis, which is the inflammation in the veins due to some kind of an injury, that puts them at risk for developing venous insufficiency. This is just kind of further definition of venous insufficiency. These patients typically result in having bilateral edema if it's damage to the valves in both of their legs. Something called stasis dermatitis can develop after chronic venous insufficiency, and that is the discoloration of the area of the calf. It's usually the anterior part. And it's usually like a brownish discoloration. I have some pictures of it coming up, and you've probably seen this in some of your patients. The stasis forms as a result from the edema and the minor injury to the limb, and it can lead to stasis ulcers, which is an ulcerated area in the lower extremity. These typically occur in the area of the inner ankle or the outer ankle. The ulcer usually has irregular borders. And these are chronic usually and are difficult to heal. And usually it's because of the poor circulation in the patient. That's why and a lot of times diabetics may get this as well because of the poor circulation. So it can be very difficult to heal and can lead to infections and things like that. There's a good table in your book about venous insufficiency and how to prevent complications related to venous insufficiency. It's patient and family education. And it talks about doing things like wearing the graduated compression stockings, also known as TED hose, to help the blood flow return to the heart. It prevents edema. And it's careful to make sure that the stockings are applied appropriately and they fit well. And when they're too tight, they can actually cause more damage than good. So it's important to understand how to measure them and make sure it's a good fitting TED hose and that it's not bunched up and wrinkles are in it because that can actually damage the skin. It's important that these patients are also taught to try to put their legs up at least 20 minutes, 4 to 5 times a day. So if they are somebody who maybe has a job where they stand or sit for long periods of time, they need to possibly ask their boss if they can, if they develop venous insufficiency, if they can have periods where they can put their feet up on a stool for at least 20 minutes, 4 to 5 times a day. Also, they should not cross their legs It impedes the flow of blood back up to the heart as well. And wearing restrictive tight clothing, especially on the lower extremities, can also impede the blood flow back up to the heart. So lots of different non-surgical management and prevention that we can do for a patient. We'll talk about the surgical management and drug therapy in the next few slides. This is just a picture of showing what the veins begin to look like in venous insufficiency. So these are the normal valves. This is when a valve gets injured, and then this is the pooling of the blood that begins to happen and cause edema and pooling of blood in the patient's lower extremity, and then ultimately damage to the skin surface due to the constant venous hypertension, which is secondary to the pooling of blood, and it starts to cause pressure on the outer layer of the leg and can cause damage, the venous dermatitis and then the venous ulcers if it's prolonged. This is just again revisiting the definition of stasis dermatitis. This is as a result of venous insufficiency and venous hypertension. And really the goal, the focus of treating venous insufficiency is to decrease edema and promote venous return from the affected leg. They usually are hospitalized for venous insufficiency, but again, it's helping to promote blood flow, so it's TED hose, it's putting their feet up, and again, just reviewing that table in your book about patient education on venous insufficiency. Stasis ulcers results from prolonged edema or from minor injury to the area. So as you can imagine, these swollen lower extremities are very prone to injury if they bump them just because of the tightness of the leg. They can be injured and very easily. And then they're typically difficult to heal because of the poor blood flow. For treatment for venous stasis ulcers, non-surgical, typically these patients have to be seen by wound care. There's several types of dressings that can be applied to the ulcers, and they often are difficult to heal. The important thing to note is once a patient has a venous ulcer that has healed, it's very important for them to do the interventions to prevent it from happening again, because they're at risk for having another ulcer once they've already had one. A couple of dressings, and it's really up to the physician and the wound care specialist. Hydrocolloid dressings are often left in place. They can be left in place for 3 to 5 days for best effect. Of course, using medical aseptic technique when changing the dressings is imperative so that they don't get an infection. An Uniboot is another dressing that can be applied for a patient who is ambulatory. An Uniboot dressing is constructed of gauze that has been moistened with zinc oxide. And basically they apply it, it's kind of like a cast almost, but they apply it and it kind of dries a little bit, and then they cover it with like an ACE wrap. And it kind of hardens like a cast, and it does twofold. It promotes venous return and prevents stasis, and it also forms a sterile environment for the ulcer to hopefully promote healing. And usually the boot is changed a couple times a week. So oftentimes a patient with an ulcer needs a dressing to the ulcerated area, and then they also will have specialized TED hose applied to or an Uniboot applied, because they still need to make sure that they wear some kind of hose in order to promote that venous return to prevent their ulcer and their stasis from getting worse. This is just a picture to, again, just kind of give a visual for what a venous ulcer is and where it most often occurs. It most often occurs in the outer or the inner ankle. And this is where the dermatitis, often you'll see it kind of down the front of the leg due to the venous insufficiency where the blood is pooling in this area. And these are just some more pictures to discuss varicose veins and kind of compare and contrast them to the other disorders that we've already talked about. This picture shows the venous dermatitis. This shows see the difference between the legs. This leg has got some venous insufficiency, and it's showing some swelling. And then here is an inner ankle ulcer. The other thing that can happen is the bulging of the veins due to the incompetent valves. These are just bulging, distended veins. That's what varicose veins are. And they can lead to, they can be very painful, and they can lead to venous ulcers. And then basically, they're just kind of not very pretty, and they can also cause the patient to have discomfort. So again, a patient with varicose veins, that's those bulging veins due to the incompetent valves. The treatment is very, very similar. They need to wear the stockings, the TED hose, to promote the venous return to prevent the bulging of the veins, and of course the elevation at least 4 to 5 times a day, elevating their feet for 20 minutes. If it becomes so painful, and also cosmetically, if they want to have them repaired, they can. Sclerotherapy is the injection of a hypertonic saline into the vein that can actually just kind of kill the vein, and so it basically blocks the vein, and so there's no longer blood flow to that vein, and then the bulging should stop. And if the patient continues to have a lot of discomfort and a lot of bulging and continued worsening of varicose veins, or it's some surgical removal of the veins that can be done. And sometimes this radio energy heat, it's kind of like a laser, can actually do similar treatment as the sclerotherapy to actually just cut off the blood flow to that vein so it can no longer be bulging and painful. Typically, the varicose vein issue is more cosmetic, but it can at times lead to just pain for the patient, especially if they're working a job where they're standing a lot. It might need repair, and also they definitely need to continue to use these two preventive mechanisms in order to prevent any further issues with varicose veins. Just some more pictures to identify exactly what we're talking about when we're talking about varicose veins. These are where the walls and the valves become weakened within the veins, and then it causes just a backflow of blood that causes bulging and distension of the vein. And in comparison, here's what a healthy valve looks like within a vein. More pictures just to get a better visual of what we're talking about and how these can become super painful. This bulging and distension right here when a patient walks can become very, very difficult and painful. So this is where the sclerotherapy or the surgical removal of the vein might be necessary. This concludes the presentation for Module 10, Part 2. The following slide is just a couple of questions and practice for doing some dosage calculation related to the medications associated with this module. I encourage you to attempt to answer them, and we will go over the answers in class for these questions.